My name is Norman Swan. I produce and present a program called The Health Report on ABC Radio National. It's important before we do anything else to pay sincere respects to the traditional owners of this land, the Gadigal clan, and to elders past and present. To set the scene, but also in terms of our co-hosts, if you like, GP New South Wales and South East Sydney Local Health District, it gives me great pleasure to introduce Gerry Maher, who is the new CEO of the South East Sydney Local Health District. Hails from Glasgow, which is where I come from, so I will do simultaneous translation for you. And has worked in Dundee, which is kind of northeast of Scotland, kind of mid-northeast of Scotland, where in fact some very good examples of integrated care have emerged, particularly one that many people in Australia know about, which is the Integrated Diabetes Care Project, which covers the whole of Scotland and is really incredibly impressive. The thing also to take note of is we're used to people coming and telling us how it's all marvellous, and we're going to have Martin McShane later talking about how marvellous it is in the English NHS. I have to say, as a Scot, the Scottish NHS has managed to avoid the multiple reforms that have happened in the English NHS and is probably a bit more successful, some would say, but we might have a debate about that later over morning tea, and Martin McShane might be leaving the room now. Please welcome Gerry Maher.
Good morning, everyone. The 13 years in Dundee's slightly softened my accent and slowed it down, so hopefully you can understand. It's actually a real pleasure to be here this morning, and I just want to first of all thank Novartis for sponsoring and helping this event happen, and mostly for bringing Martin over to spend a week. I met Martin coming out of the Minister's office yesterday evening. I had a very successful meeting with her, and I know, Martin, that they're making sure every minute of your time is being deployed. I'm sure your jet lag will survive you by the end of the week, but thank you very much, and I know that you've got a very extensive and busy programme. Regrettably, I'm not here for long, but I wanted to come here, one, so that some of the people from the district would recognise who I am, but more importantly, I really wanted to associate myself with this particular topic. I think it's probably the most single challenging topic and challenge that we face in health systems across the world. On the 14th of April this year, the government in Scotland is approving primary legislation to actually bring integration of health and social care together. Such is the importance that our government place on integration, and I know that Martin, in the work that he's doing, will emphasise that as well in England. And across the world, everyone is beginning to really understand the challenges of not just the demographic shift in the population, but the emerging understanding and sense that we have of the challenges of comorbidity and the impact that that has not just on capacity in hospitals, but more importantly, the lives of people who are living with illness and living with comorbidity, be it at home or unfortunately in a nursing home or on occasions in hospital. So everyone's did this exercise, so we did it not so long ago in Tayside. We decided, so if we just didn't rise to the challenge and didn't accept that we have to absolutely fundamentally transform the way we think and the way that we do things, what would be the impact on the system in the region of Tayside in Scotland? And we simply extrapolated our data, extrapolated our activity, and by 2031, it told us that we'd have to build another 530-bed acute hospital in the city of Dundee. Now that's preposterous. One, there is no money in health. Increasingly, I think Australia will be saying there's no more growth in health as well. It's not the right thing to do, and it just is simply unfeasible. And so that's energised us and energised all international partners to think very seriously about how we reorder our thinking about the challenge of integrated care, and to shift the balance of care in a meaningful and dramatic way in favour of forever emphasising the need for people to be at home where they're most comfortable. And for me, the greatest thing that's emerging from this debate, and Martin, I was refreshing myself on the website on your programme, and some of the tweeting and messages that are coming back, and at long last, we're now beginning to realise that the greatest asset in anyone's circumstances or illness is themselves. And that we have to design and plan and think conceptually about the idea that the patient, the person, the family are the assets in this drama of their lives and their illnesses. And what I'm seeing emerging across countries are systems beginning to redesign the whole issue of self-management, support, anticipatory care, and effective rehabilitation when people perhaps have an episode of care that puts them in hospital. But I think the conceptual idea of an asset-based approach is one that I think shows great potential. And yes, there is no magic bullet, there is no single model emerging around the world that we can rush to, but I think there is a lot of evidence emerging. The challenge for governments, the challenge for CEOs and systems of care is that we have to scale up very, very quickly. We've got good evidence of points of care, of programs of evidence emerging, but the economic and demographic challenge for me is that over the next 10 years, systems in Australia, in America, in England, in Scotland will have to move to scale at a level that we have never, ever given consideration to. And the key to that will be the integration of care that shows meaningful movement of people away from hospital-based care into their communities and with their families. So I have a strong personal interest in this. For those of you in the district in South Eastern, I look forward to working with the local communities and with the local people on this programme. Wish you well for the day. Know that you've got some great contributors and that you've got time and space to actually talk these issues through away from the busyness of the normal working day. So have an enjoyable day. Thank you for the opportunity, Martin, to come along and address the opening of the conference. I will leave now because I've got to be somewhere else, but many thanks.
I want to ask, because you're not going to be here and you've got some experience, a lot of experience in this area, and this concept of building it around the patient, the family, self-management. So one of the responses consumers give to that is, well, you're dumping on us. And this notion of responsibility and us, and we swim in the system, and doctors know more than we do, you health managers know more than we do, and you're just casting us adrift. What's your answer to that, and what structurally do you have to put in place?
Well, I think that, and I followed in after Martin with the Minister, and we had that very conversation yesterday, because it can be a political challenge. I understand that perception, where culturally communities have been trained to depend on doctors and nurses in a dependent way in hospitals, and the currency is measured by how many beds there are in the community, not by the level of resource. So I think that what we need to begin to do is really begin to empower communities to equip our nurses in particular and some of our allied health professionals, and we've retrained them to be coaches rather than nurses, to deploy skills of personal intervention with people, to work with them. We've engaged our communities in self-help groups. It's really interesting, the COPD group in Angus, in one of my regions, have started their own group. They call themselves Breathless Not Helpless, which I thought it was their idea.
Pink, not blue.
Yeah. So the whole notion of energising the community, making real resource transfer. If people don't see the resources, either capital, financial or human, transferring over into that locality, they'll continue to be suspicious about that's rhetoric, and the infrastructure is still in the hospitals. And that's where we feel safe.
And just one more question then. There's then a transition in investment from, there's still fragmentation in Britain, even though it's less than here, between primary healthcare and hospitals. But how do you actually shift investment to that while you're still pressed to get through your artificial hip waiting list and your knee waiting list, etc., etc.
So my general response to that, well, whatever the subject, I say that could CEOs and other systems stop worrying about the 5% and start concentrating on the 95% and spending it better? Because in actual fact, when you look at the evidence, the level of waste and significant variation in our system, I believe, releases resources that you can start to make that transitional investment across into primary and community care. But it takes a different way of thinking. I'm not just thinking about the dollar and about savings and about shaving the budget. It takes a fundamental rethinking about how you can transition and transform care into the community.
We all got this idea about what integrated care might be. Not really many people know, if anybody at all, how to actually turn that idea into reality on the ground. The plan was that this workshop was follow on from the workshop that the Ministry of Health was going to run at the end of February. Unfortunately, their dates couldn't get locked in. Ours already were, so we're going ahead with this nonetheless. And I think there's some people from the ministry here today as well, so thanks to you for your support in putting General Practice New South Wales together with South Eastern Sydney Local Health District, and we've ended up being able to co-sponsor this event. But we've also been very actively engaged with Martin McShane, who's had some seriously interesting conversations with a range of players in the primary healthcare space over the last few days in Sydney, and tomorrow and Friday again in Canberra. We're all anxiously waiting for the Medicare Local Review, or for the government's response to the Medicare Local Review, because that will, to some extent, determine the future of primary healthcare in this country. My organisation, General Practice New South Wales, used to look after the divisions of general practice, and we were responsible to support the divisions' transition to become Medicare Locals. And then we weren't actually abolished, we were just defunded. But in the Commonwealth's mind, that's the same thing. And I was hired at the end of December 2012, and the charge was reinvent the organisation. And we've had a number of different goes at that. We've worked very closely with the Medicare Locals. The Medicare Locals are still our member organisations in New South Wales. Almost all of them are engaged and active members. And we work very closely with the Australian Medicare Local Alliance, the national body that's charged with the coordination of Medicare Locals across the country. In the meantime, however, my board has also decided that what we need to do is to reinvent ourselves as a broad-based primary healthcare sector body. What does this look like? It's going to look like something akin to what the people in Queensland are doing in Checkup, but what we're aiming for is to build a broad-based alliance of organisations, or stakeholders interested in primary healthcare, consumer groups, providers, professional organisations, industry bodies, allied health, nursing organisations, unions, Medicare Locals, and any other sort of organisation that wants to play in that particular space. In Queensland, a number of the local health networks or districts are involved in Checkup, and we think they've got a key role to play as well. So what this all will look like depends on what we get out of the federal government in May around the Medicare Local Review. Ultimately, we're a member-based organisation, and we will have to be guided by what our members want. The board has also agreed that we rebrand ourselves, and this will happen in May. We will be called Primary Care New South Wales. Now, we don't want to lose our connection with GPs. That's a very important part of the equation in terms of primary health care. So the name General Practice New South Wales is quite a powerful name in that sense, but really the stakeholders in primary health care are far more than general practice, although they are a key part of the structure. So Primary Care New South Wales is the organisation you need to be looking out for from May onwards. Ultimately, the organisation at the state level needs to exist, even though the federal government doesn't think that's the case, in the fact that everybody else continues to want to have some sort of state machinery to bring together the players around primary healthcare, and my organisation aims to fill that role and fill that hole, in fact, because there's nobody else doing this. When we've consulted widely on the process of re-establishing the organisation as Primary Care New South Wales, we've received a widespread support, and nobody's saying, hang on, you can't do that, you're competing with us and it's our space. So we're very positive about where we're going as an organisation, and we'll regroup in May once we know what's happened to the Medico Local Review process, and look forward to working with you all under the new banner of Primary Care New South Wales. I hope you have a very productive day today, and I look forward to working with you all. Thank you.